well known and understood. So, ep- epidemiology is what determines, and we understand the enormity of the problem. It is the most common sustained arrhythmia now, as has been told in the previous two talks. There's a paradigm shift evolving in favor of rhythm control rather than rate control for even a new onset atrial fibrillation. The prevalence, I'm sure, we see it's ever increasing. I don't have to go into it. And what's important is the lifetime risk of developing atrial fibrillation is pretty high, from a prevalence of about 1 to 2 at age 80. It's something like 10 per thousand. So the prevalence is going to ever increase as the aging population increases. The risk factors for incident AF, this is given in all standard textbooks, but importantly highlighted by the ESC. Aging is a very important risk factor, and we're going to have all the so many comorbids which affect atrial fibrillation. So this determine the eventual success of us favoring rhythm control. Why it is important to treat atrial fibrillation? Because the outcomes are pretty pathetic, even in asymptomatic patients. To symptomatic patients, they can be directly or indirectly responsible for death, can cause stroke, we all know that, LV dysfunction, heart failure, cognitive decline, depression, impairment of quality of life, and frequent recurrent hospitalization. So that needs to be borne in mind too, and that's the reason we try to maintain these patients in sinus rhythm all the time. The contribution of individual risk factors to development and sustenance of atrial fibrillation is very important to understand, because it translates into poorer control when we have when we are going to adapt a rhythm control strategy. For example, if a patient has all of this and I'm trying to achieve a rhythm control, it's going to be very difficult. It's foolhardy. So I have to have a very judicious approach right from day one, from the word go, whether I can maintain and sustain these patients on in sinus rhythm. So these factors, they act in isolation, and when they are multiple factors together all the time, they are multiplicative, and our response to rhythm control strategy is not going to be favorable. If you look at the recommendations, catheter ablation for as far as pulmonary vein isolation, whether it is fire or ice, whether RFA or cryoablation, is strongly recommended. Class 1 for rhythm control after one failed or intolerant class 1 or class 3 antiarrhythmic drug. So it's very important. Even today the guidelines are very clear. We need to try one drug unless the patient himself asks for an ablation upfront. So paroxysmal AF, the subset of patients whose left atrium is not big, who are the ones who respond best. Persistent AF without major risk factors. I showed you so many risk factors there, so we have to scratch our heads and see if the patient fits into this the criteria for a favorable rhythm control approach. And persistent AF with major risk factors for recurrent atrial fibrillation despite ablations in the past. So AF catheter ablation at this point of time after drug therapy of failure, because that's what it's readily available with us, and that's what, and this has been shown before. We have to understand this. If these patients, this is the subset of patients, younger patient as told earlier, tachycardiomyopathy, LV dysfunction, disabling symptoms, recurrent AF, rate control difficult to achieve, patient's preference, recurrent heart failure, not many comorbidities, you can offer them AF ablation. That's a general rule. An age less than or equal to 65, these patients do well. Anything above that, it's very difficult. Rhythm control is recommended for symptom relief and improvement in quality of life in symptomatic patients with AF, class 1 indication. How we achieve the rhythm control is our problem. So there are certain set principles of antiarrhythmic drug therapy. It aims to reduce AF related symptoms. The efficacy of antiarrhythmic therapies is at the best modest. So that's very important. It is not as good, not as effective as ablation. Clinically successful antiarrhythmic drug therapy can reduce or eliminate AF recurrences. That's why we persist with these drugs even after successful ablation for a period of 3 to 6 months. If one drug fails, we are duty bound to try other group of drugs so that we can achieve rhythm control. More importantly, drug-induced proarrhythmia should be borne in mind, and extra cardiac side effects with the most common drug, amiodarone, should be borne in mind. Safety rather than efficacy should primarily guide the choice of antiarrhythmic drug therapy. So we have to see, there are certain rules when we initiate the drugs. Is the patient symptomatic? Is it symptomatic enough to warrant an antiarrhythmic drug? When to start the drug? Usually not the first episode, but can enhance the efficacy for cardioversion if you want to. If you want to make sure the cardioversion works, maybe give them antiarrhythmic drug along with anticoagulation before you elect the cardiovert. And how do I choose the drug? Minimal or no proarrhythmia, no organ toxicity. All the time look at the QRS duration, baseline, look for the PR interval, look for the QTC before you initiate the class of antiarrhythmic drug you would like to. What is the LV function upfront, and what are the pharmacokinetic and pharmacodynamic interaction of these antiarrhythmic drugs with anticoagulants, which you have to use in all the time. And proarrhythmia, as I said, this risk of proarrhythmia changes from time to time. So every time we have to, when we see the patients, we have to evaluate for proarrhythmia as well. So how do I minimize proarrhythmic risk? Evaluate the ECG before initiation and during every clinic visit. Evaluate periodically for organ toxicity, particularly amiodarone. Amiodarone is perhaps the most unsafe drug. It causes toxic side effects head to foot. So we have to be knowing the side effects in great detail. Long-term Holter monitoring may be required. Avoid combination of antiarrhythmic drugs, so you may have potentially risky complications. How do I verify the efficacy? You have to estimate the burden of AF during therapy, ask the patient symptoms, and also keep doing monitoring. And any adjuvant interventions that I may do, yes, all the time patient has concomitant sinus node dysfunction or conduction disturbances, may start thinking of pacemaker along with antiarrhythmic drug therapy. And short term, as I said earlier, antiarrhythmic drug therapy can and be useful along with AF ablation. This slide has also been shown before, but then these two trials, AFCHF and Japanese rhythm, these both have heavily favored the impacted our decision making in favor of rhythm control strategy. They are able to maintain rhythm control in close to 70% of patients if the patients are maintained, taken down the route of either ablation or pharmacotherapy as well. So amiodarone is recommended for long-term rhythm control in all AF patients, particularly those with reduced ejection fraction. So if you have a patient with LV dysfunction, the one safe drug in LV dysfunction with AF is going to be amiodarone, but the extra cardiac side effects need to be borne in mind, and wherever possible we should consider other antiarrhythmic drugs. So if I look at one by one, what are the drugs which can restore the patient to sinus rhythm? The pharmacological cardioversion, oral or intravenous flecainide, the class 1C drug flecainide propofenone. The dosages are given there. We have to see whether we are using this kind of doses. We are using actually 1/3 the dose, which is not correct. So we have to use the right dose. And what the caution is, patients should not have underlying ischemic heart disease. They should not have underlying structural heart disease. They should not have LV dysfunction. More importantly, if you use this class of drugs in atrial flutter, you can actually enhance the conduction down the node, can cause 1:1 conduction. All the time these patients, when you use class 1C drug for rapid atrial flutter, you should have concomitant AV nodal blocking drugs. Can cause QRS widening. Do not use for pharmacological cardioversion of atrial flutter, preferably for atrial fibrillation. So the other drug which we routinely use is amiodarone. The dose is pretty high. Again, we have to see what kind of dose, and acute success only 40%. Can cause phlebitis, so we have to use in a big vein. It has to be preferably a brachial or one of the jugulars. Preferably use an infusion pump. Can cause hypotension, bradycardia, AV block, and QT prolongation. Thankfully, amiodarone is not as proarrhythmic as the other drugs. And if the patient has hyperthyroidism, it can cause thyrotoxicosis, so we have to have that in mind. And more importantly, it can take up to a week before the patient goes into sinus rhythm, because it has got a mere 40% reversal rate to sinus rhythm. Ibutylide is a good drug which is available now, 0.01 milligram per kilogram body weight for those less than 60 kilogram. You give 1 mg over 10 minutes by an infusion pump. Success rate for fibrillation is about 50%. For flutter is better. So if you have a flutter, ibutylide, if you don't want to cardiovert, is a good drug, and it's perhaps more effective than any other pharmacological agent for atrial flutter. Amiodarone, when we give oral formulation, it has to be given something like 200 milligram 3 times a day for a month, and then 200 milligram once a day thereafter. It is perhaps the most effective antiarrhythmic drug. It is safe in patients with heart failure. Concomitant use with oral anticoagulant and digitalis, we should be careful because the dose needs to be reduced. can cause torsades, but luckily compared to other antiarrhythmic drugs, the incidence of torsades is very less with amiodarone. But whenever the QT gets prolonged, more than 500, QTC rather, more than 500 millisecond, we need to be wary of. We will have to down titrate or even perhaps stop the drug. When you have a hyperthyroidism in the background, better to avoid amiodarone. And flecainide for long term maintenance of sinus rhythm has to be something like 100 to 200 milligram twice a day. It helps in prevention of recurrent AF. Should not be used in patients with CKD. It's contraindicated when the patient has a EF less than 45. If the patient has a baseline QRS prolonged, we should keep monitoring. If the QRS gets prolonged by 25 to 30% more than baseline, we have to stop the drug because it can cause torsades and which can be troublesome, particularly when you give an oral formulation. So these patients need to be seen at frequent intervals. For atrial flutter, as I said earlier on, it can increase this flutter cycle length so all the time and can cause 1:1 AV conduction. So better to use with the AV nodal blocking drug. Otherwise, you can have trouble, as we had trouble in one small child. She was treated elsewhere. She came with this ECG to begin with. She was on flecainide and she's been then this was the ECG subsequently. She was on flecainide without a AV nodal blocking drug, and that was the ECG after cardioversion. This is the ECG she presented with. She presented with syncope, had to be cardioverted. There was a lot of debate, and then once we cardioverted, we started looking at the flutter waves, and then she went on to have ablation of the atrial flutter. So when we use flecainide or propofenone, particularly if it's flutter, all the time use the AV nodal blocking drug along with it. Propofenone works similar to flecainide. Again, the caution is should not be used in liver and renal disease background, and the dose is pretty stiff, 300 milligram 3 times a day, and the maintenance to sinus rhythm long term is between 40 to 50% at the best. Do not use with underlying structurally abnormal heart. Do not use in LV dysfunction. Do not use when the QRS is prolonged or the QRS get prolonged at follow up 25 to 30% more from baseline. So again, propofenone also similar to flecainide. For flutter, if you are going to use, you should not use without AV nodal blocking drugs. It can also cause 1:1 AV conduction because it increases the cycle length and can cause trouble. Dronedarone has since been taken away from our market. It is less effective than amiodarone, but has less side effects because it doesn't contain the iodine moiety. But those with heart failure, this drug doesn't work at all. It is one of the good drugs which came in the past about a decade ago for paroxysmal AF, but not for rhythm control. It has got a good safety data, but it is not as efficacious as amiodarone. So can be used when we use anticoagulant, should not use with dabigatran because it potentiates the effect of dabigatran several fold. When we use along with other blocking AV nodal blocking drugs like digitalis or beta blocker, we need to lessen the dose of dabigatran, dronedarone. There's a small but definite increase in serum creatinine when these patients are on dronedarone, but that's not a cause for big worry. So basically, dronedarone for those paroxysmal AF with a structurally normal heart when we don't want to use amiodarone. Sotalol is the other class 3 drug. It got beta blocking property as well, but it works as a class 3 agent only when the drug dose is more than 160 milligram per day. So if you're going to give 40 milligram once or twice a day, you're not going to achieve the class 3 effect of sotalol. It may not be effective. Importantly, it can cause torsades much more than amiodarone by virtue of it causing hypokalemia. So we have to monitor the potassium levels all the time when we give sotalol, and it can cause QT prolongation because of its effect on potassium. It causes hypokalemia as well. So it's better not to be used in reduced ejection fraction heart failure where amiodarone scores over it. Particularly patient has significant LVH and baseline prolonged QT interval or baseline hypokalemia, or if the eGFR is less than 30 ml per minute. So many ifs and buts for sotalol. It's again it's a potassium channel blocking drug, increases with increasing dose, and consequently the risk of proarrhythmia also increases when we use higher dose of sotalol. Disopyramide is also quite a good drug, and this is particularly useful in vaguely mediated AF and particularly hypertrophic obstructive cardiomyopathy, where it's believed to reduce the outflow tract obstruction. There is a higher mortality with disopyramide, hence this drug is not preferred. It has got atropine-like mechanism. And what is the indication for long-term rhythm control, which this has been discussed earlier on? We have to assess and treat all the risk factors and the comorbids. We have to use other drugs which are also have a favorable effect, like RAS blockers, mineralocorticoid receptor antagonists. There is some role for statins, but then it has been debated all the time, and we have to assess whether the patient has minimal or no heart disease, no structural heart disease, whether the patient has reduced ejection fraction or not, whether the preserved ejection fraction or not. Structurally normal heart, we can see the kind of pharmacotherapy which is a class 1A indication. Of course, dronedarone is there on top, which is not available in our country anymore because it's not as efficacious. And catheter ablation all the time scores over pharmacotherapy, so we have to have that in the back of our mind. And if the patient has reduced ejection fraction, the only drug you can safely give to the patient is amiodarone, or else offer them catheter ablation. The non-antiarrhythmic drugs which were believed to have favorable effect in atrial fibrillation, ARBs did not reduce. So there was some talk in the past that receptor blockers can reduce the incidence of AF, but that has now been negated. Similarly, if you look at beta blockers, though it controls the rate, most evidence now pleads against a significant role of beta blockers in preventing AF. It's only going to control the AF rate of AF. It's not going to abolish AF altogether. So, mineralocorticoid receptor antagonists, by reduction of atrial fibrosis, have some effect in reducing the burden of atrial arrhythmias. Statins have failed to show a beneficial effect. So, it's very important. Statins have to be used as part of risk factor modification. It cannot be used in isolation for control of paroxysmal AF. So, strong recommendations for antiarrhythmic drugs, class 1 level of evidence A, flecainide or propafenone, the 1C drug for long-term rhythm control, those only with normal LV function, because we do not want to buy the extra cardiac side effects of amiodarone. The moment the patient has LV dysfunction, we are looking at amiodarone as the only drug. We are not going to look at other drug. If amiodarone fails, then we are probably looking at catheter ablation of some sort. Dronedarone is recommended for rhythm control in place of amiodarone in those with normal or mildly impaired EF, but this is not available in the country. So this slide has been shown how we handle permanent from non-permanent AFs. I will not delve into it, but there are a subset of patients who do not do well with any rhythm control strategy, whether it is ablation or pharmacotherapy. We need to resort to AV node ablation and then give them pacemaker of some sort. If the EF is less than 45, we give them CRT. If the EF is above 45, we may do maybe a one lead pacing, probably a conduction system pacing. This slide also has been told very clearly. We have to draw our attention only to this half of the slide. Dr. Lawrence spoke elegantly about this. Whenever there's a poor rhythm control, then only we think of rate control. All the time we should try and achieve rhythm control. Of course, using rate control strategy along with rhythm control, whether it is by way of drugs or ablation. There are futuristic drugs in the pipeline, before I wind up, where we are looking at safe and effective alternative antiarrhythmic drug therapy. There are what is called small conduction calcium activated potassium channel inhibitors. They are showing promise. There's a TWIC related acid sensitive potassium channel inhibitors like potassium channel inhibitors, amiodarone and sotalol. Slow sodium channel inhibition, which acts on the phase 0, and multi-channel inhibitors acting on all the channels of the action potential. Thereby, in some areas it prolongs the action potential, some areas reduces the action potential. Thereby, it can get rid of AF on a long term. So there is a paradigm shift underway towards offering early rhythm control to all patients with recent diagnosed AF, which is at the moment not reflected in current guidelines. All the time, all of us who treat AF want to have our patients in sinus rhythm. There is overwhelming evidence which supports early intervention in all patients with AF that has not become long-standing. We should intervene early to prevent irreversible structural atrial cardiomyopathy, or those who have unmanageable symptoms, or who have a stroke or are at a risk of stroke. So all the time CHRS has to be factored in. The continued evolution of treatment for atrial fibrillation, this very highly complex disease, will result in antiarrhythmic drugs with a better safety profile than previously available, because our patients do not have access to interventions of all kinds. improved ablation in the form of cryo has been so elegantly shown by the previous two speakers, probably is the right way forward, where we can, without even offering pharmacotherapy, offer cryoablation upfront, so that we can not only reduce the AF burden, we can virtually eliminate AF recurrences, especially when we deliver it early in the course of the disease process. Thank you very much. I'll be happy to take questions if any.